Aloha, welcome back to Journal of Pharmacology. Let's move the PowerPoint slides and get started today with even more endocrinology. We should be talking about 4.2 endocrinology, but we need to finish off from the first endocrinology lecture. So that being said, we should be somewhere around slide 80 and start talking about the pituitary gland. Most endocrinology lectures start with the pituitary because that's certainly interesting. We started with diabetes mellitus, and with all the exciting things going on with diabetes mellitus, it's made it hard to get through the pituitary lectures in a reasonable manner of time. So we're going to start today by talking about the pituitary, and then we'll move on to the curriculum you'll see in 4.2. So again, this is at the end of the 4.1 Endocrinology 1 notes. All right, so this is a slice through someone's brain, and this is the anterior part of the brain, the front of the brain. That's the optic chiasm right there, so they would be, their eye would be here looking that way, and the whole point of all that is to show you at the base of the brain is this thing called a pituitary, and if we make that pituitary cartoon bigger, we'll see it's below the hypothalamus, and there's an anterior pituitary and a posterior pituitary, and if you get real deep into it, you can see that things will be made up here and transported down here, unlike here where the cells are there. And that's all complicated, so I don't really need you guys to know that from a clinical pharmacology point of view. What I want you to remember is the front half does one thing and the back half does the other. The anterior part keeps us in front of the growth curve, and the back part, it deals with water. If we can remember that, we'll be doing just fine. So let's start with the front half of the pituitary. Again, these endocrine organs are going to be like several organs in one. They get an anatomic name because they're in one location. But even though the pituitary is in one location, there's two halves of it, and then if we look very deeply, we can see that the front half and the back half each have different individual functions within them. So we want you to get away from the mentality that an endocrine organ has one specific function. It doesn't. It has multiple functions because there's multiple cells that are doing different things involved in different aspects of regulation. We're going to talk more about the anterior pituitary. Certainly when we talk about the thyroid, we'll talk about thyroid stimulating hormone. And when we talk about adrenocorticotropic hormone, we'll talk about ACTH. Follicle stimulating hormone is involved in releasing follicles from the ovary. Prolactin pertains to the growth of breasts. There are other tropins. Melanocyte stimulating hormone should be in here. That's important for people in dental hygiene. And so not only these anterior pituitary hormones stimulate the growth of individual organs, this growth hormone right here stimulates the growth of the entire body. And so there's different layers of how much growth, the selectivity of growth from the anterior pituitary. So again, we remember anterior keeps us in front of growth. The word tropin comes from tropics, and everything loves to grow in the tropics, and we know that here. I think we're off by, we're in the tropics, we're in the subtropics by 2 degrees, I think. But here in a tropical location like Hawaii, we know that tropical means encouraging growth, and so that's where that word tropin comes from, encouraging growth. And so the anterior pituitary secretes hormones that encourage growth, not only of the entire body, but the milk-making apparatus, thyroid stimulating hormone, adrenocorticotropic hormone, follicle stimulating hormone. So we'll talk about these as we go along, but I think we start out talking about growth hormone. So again, the anterior pituitary releases tropic hormones that stimulate endocrine glands to grow and produce hormones. And these hormones will be released into circulation. Again, releasing hormones into the circulation, into the blood supply to communicate with other organs is our definition of an endocrine system. All right, to start out, the anterior pituitary stimulates the growth of the entire body. It does this through something called growth hormone. And so to see what growth hormone does, we'll show you some examples of disorders of growth hormone. The first disorder of growth hormone we'll talk about, we'll talk about giantism. It's also called gigantism. I always referred to it as giantism, but I get plenty of emails telling me it's also referred to as gigantism, especially in Europe. And so the key point of giantism or gigantism is that this occurs in children. All right, so our bones have these epiphyseal plates, and once we get at a certain age, somewhere in our 20s, these plates will close. And so the long bones cannot grow longer after the epiphyseal plates close. And so if children are exposed to excessive amounts of growth hormone, their bones can grow larger and larger and larger and larger, or longer and longer and longer and longer. So again, children can grow up to 8 feet tall, weigh over 300 pounds if gigantism, the excessive secretion of growth hormone in children, is not treated appropriately. So Robert Wadlow was 8 feet 11 inches tall. He weighed nearly 500 pounds. However, the body is not designed for this, and so even though he seems like he's having a really good day there, he died at 22 years old, most likely of heart failure. This is when I start getting emails because Robert Wadlow has quite a following out there. All right, well, acromegaly is growth hormone after childhood. So after those long bones close and they can't grow any longer, then the excess of growth hormone does not result in the adult getting taller. It results in them getting bigger. And so Andre the Giant was the star of Princess Bride, if you made it through that. And he was also, before that, a famous wrestler. So he had a pituitary tumor. He had an anterior pituitary tumor that secreted too much growth hormone. That resulted in him being 7 feet 4 inches tall, weighing over 500 pounds. And again, the body's not designed for this. So he died of congestive heart failure because of the fact that he was a giant and that was part of his occupation. He did not want to be treated for this pituitary adenoma. And somewhere in my slides I used to have this, and I think I can put it on with the video editor. Something that I want you to see in the facial features of this person, of Andre the Giant. I want you to see those raised eyebrows. The periorbital ridges of his skull are more pronounced. Notice the more prominent cheekbones and the more prominent jawbone. And so I need to remind myself to get the x-ray for this, and then I have a political cartoon. I have a cartoon, and the cartoon is a before and after picture, and it's talking about baseball players, and the cartoon shows some professional baseball player, their rookie card, and he is this skinny baseball player when he's a rookie, and then it says baseball card now, and it shows him, that rookie, he's all buffed up. But something that's very interesting about that cartoon is they made a reference, they drew in the prominent periorbital ridges above the eyes, the prominent cheekbones, and that protruding chin as being evidence of the use of growth hormone. And so something I want you to keep your eye on with professional athletes is when they are young, they don't have any of these features, and then later on in the careers, when you start to notice your favorite athlete having enlarged ridges above their eyes and prominent cheekbones and a protuberant chin, that's evidence of them using an analog of growth hormone. On TV, they call them anabolic steroids, and that's not how we talk about that in pharmacology. We'd call that an analog of growth hormone. So one of the main reasons I have this on there, and I used to have an x-ray on my next slide, I wanted you to see those characteristic features because we see the use of synthetic growth hormones in professional athletes. And it's very obvious to some of us. All right, well, octreotide is sandostatin. It is a synthetic form of somatostatin, and it's an inhibitor of the release and the function of growth hormone. Somatostatin comes from the delta cells of the pancreas, and so it is a naturally occurring hormone in the body. We can synthesize that in a drug called octreotide, a medication called octreotide sandostatin. This will be a drug that we can use to inhibit growth hormone, excess growth hormone. Again, if it's due to a pituitary tumor, then either surgical or other ablation of that tumor will be the treatment. But this is a pharmacology class, and so we have to talk about this stuff. There are pituitary adenomas. Somewhere in the slides we talk about something called a functional adenoma. And a functional adenoma is just quite simply an adenoma that produces too much of the hormone of wherever it's located. So a thyroid adenoma would make too much thyroid hormone. A pituitary adenoma would make too much hormone of wherever in the pituitary that was. And so be on the lookout for the term adenoma and functional adenomas, because functional adenomas are quite simply little tumors that grow inside of an endocrine organ and secrete too much of that hormone. Now, some adenomas can be cancerous, but in endocrinology, when we talk about an adenoma, a functional adenoma, they're just quite simply little tumors that secrete too much of the hormone that's being produced in that area. And so here we have a pituitary adenoma that secretes too much prolactin. We'll hear that called a prolactinoma. And this is actually quite common in young women, and you will see young women who have excessive milk production without being pregnant, and that's usually the first indicator of a prolactinoma. Something I want you to keep in mind is this. It's treated with bromocriptine, Parladel, an ergot alkaloid dopamine agonist. And so if you look up bromocriptine, Parladel, it will tell you it's an anti-Parkinsonian agent because most ergot alkaloids that are dopamine agonists are usually anti-Parkinsonian agents. However, dopamine agonists are used in the treatment of prolactinomas. And so if you see a woman who is being treated with bromocriptine, Parladel, an anti-Parkinsonian agent, remember that this drug is used routinely in the treatment of a prolactinoma. And so now things in pharmacology have gotten complicated. I want you to be very careful about looking up drugs like bromocriptine and saying, oh, well, that's an anti-Parkinsonian agent. This person must have Parkinson's disease. And you look at them and they're like, well, they don't look like they have Parkinson's disease. You're on an anti-Parkinsonian drug, and they'll look at you like, well, I don't have Parkinson's disease. Where are you coming up with that? Like, well, you take bromocriptine, Parladel, it's for Parkinson's disease. And no, they're not using an anti-Parkinsonian agent for Parkinson's disease. They're using a dopamine agonist ergot alkaloid in the treatment of a prolactinoma. So again, be very careful about describing these drugs in their therapeutic classes, meaning, oh, that's an anti-Parkinsonian agent. That person must have Parkinson's disease. Everything that we talk about moving forward, you've got to be very careful about drawing those assumptions. I think we've made that point. We're going to come back and talk about the anterior pituitary, how it relates to the thyroid gland, and how it relates to how it relates to the adrenal gland as well. Right now we're going to take a detour and talk about the posterior pituitary. And what I want you to remember about the posterior pituitary is it makes anti-diuretic hormone, prevent diuresis, anti-diuretic. Antidiuretic hormone is required for your kidneys to retain free water, retain fresh water in the body. By the way, antidiuretic hormone is also called vasopressin, vasovascular pressor. Antidiuretic hormone, not only does it cause us to retain free water, it's also a vasopressor. And so we used antidiuretic hormone, we used vasopressor as a pressin in the treatment of cardiac arrest. Oxytocin is also made by the pituitary, and we will use synthetic forms of oxytocin in the delivery of a child in certain situations. I don't talk too much about that because I find all this up here much more fascinating. So let's talk about the posterior pituitary. It's involved in water regulation. From a clinical point of view, that's what I want you to remember about the posterior pituitary. If you are in the labor and delivery business, then you need to be aware that the posterior pituitary also makes oxytocin, which is involved in milk production and uterine contraction during birth. You'll hear it called milk letdown. It stimulates the breast to secrete milk for the baby and also secretes uterine contraction. Again, antidiuretic hormone is vasopressin. It is very important in the balance of water and osmolarity. Osmolality, for clinical purposes, there's no difference between osmolarity and osmolality. That's fun to read about and talk about, but from a clinical concept point of view, there's no difference. It prevents diuresis. Antidiuretic hormone prevents diuresis. It prevents free water loss. Free water is the equivalent of fresh water. We call it free water in medicine because it's a lot easier to add salt to the water than it is to free it from the salt. And so free water is fresh water. And so antidiuretic hormone causes us to retain this free water, prevents us from losing free water through the kidneys. So if we don't have antidiuretic hormone, we are going to lose an enormous amount of free water from our kidneys. All right, so antidiuretic hormone, vasopressin, is our posterior pituitary way, the brain's way of communicating with the kidneys and other organ systems in the balance between free water and osmolarity and osmolality. And so again, antidiuretic hormone communicates with the kidneys, telling it to retain free water. Antidiuretic hormone is required for the proper retention of free water and the balance of free water with the solutes. Again, the posterior pituitary also makes oxytocin, which is involved in allowing the milk production to flow towards the child, and it also causes uterine contraction. So we can use a synthetic form of oxytocin in labor and delivery if labor's gone on long enough and they want to stimulate uterine contractions. We can use a pit drip is what they'll call it. It's a synthetic form of oxytocin. But keep in mind, this causes uterine contractions, and contracting a muscle for too long will shut off its blood supply. So if you're in the labor and delivery business or you're heading in that direction, the most important thing I want you to know about oxytocin is that it will cause uterine ischemia, uterine infarction if it's used in excess. So we have to make sure that when we use it just enough to stimulate the birthing process without shutting off the blood supply to the uterus. Back to water regulation. All right, we're going to talk about two things. We're going to talk about SiADH, and then we're going to talk about DI, and they are opposites of each other. So we'll start with SiADH. SiADH stands for syndrome of inappropriate, and you can write too much next to inappropriate, antidiuretic hormone. And so syndrome of inappropriate antidiuretic hormone, syndrome of too much antidiuretic hormone, that means they retain free water. And so I want you to think about what's going on inside of the body as fresh water levels go up. And so if you have a saltwater aquarium and you pour a bunch of fresh water in it, well, and then you measure the sodium level, it'll say the sodium levels dropped. But you didn't lower the sodium level. You didn't take away sodium from the fish tank. All you did, you didn't take salt away from the fish tank. All you did is add water to it. And so that's what we see with syndrome of inappropriate antidiuretic hormone. We're just quite simply adding a bunch of fresh water to the salt water within our vascular system. And so the first thing we're going to see with this increase of what we'll see with the increase of fresh water is the decrease of sodium levels, decrease of sodium, because we're basically diluting the sodium. So again, a syndrome is any set of symptoms that define that disease process, and so fluid retention, because we're retaining free water because we have too much antidiuretic hormone. And we'll have serum hypoosmolality or osmolarity, and hypo low, and so hypoosmolality is the same thing as low salts, low glucose, low solutes, the stuff in the water. And so because we're retaining free water, we're going to see lower sodium levels. And that makes sense because, again, that's why they call it dilutional hyponatremia. The lower sodium levels only mean that there's more free water in the system. This has to occur with normal renal function because the kidneys have to respond to antidiuretic hormone for the syndrome to occur. So SIADH requires normal kidney function. And then again, if we're retaining free water, what we see is a loss of sodium. What we'll see is hyponatremia. They won't lose sodium. They'll be retaining free water. Again, antidiuretic hormone causes the kidneys to retain free water at the late part of the collecting system. Something I want you to be aware of is that all sorts of central nervous system medications, where is that? We'll get to that. Something I want you to be aware of, not only all sorts of central nervous system medications can result in SIADH, but something that we see that's very common is that tumors can make inappropriate antidiuretic hormone. Because the antidiuretic hormone is polypeptide hormone, it's very small, and so it's a simple molecule for tumors to make by mistake. They'll secrete substances in the process of being a tumor, and the body will mistake that for antidiuretic hormone. And so something that we'll see in SIADH, something that we'll see is that lung tumors can be found by quite simply a chemistry and looking at their sodium levels. And so I had a patient in the hospital back when I did that sort of thing, and his sodium level was very low. And because his sodium level was very low, I wanted a chest x-ray, and he had been admitted for one thing. He'd come into the emergency room and been admitted for overnight observation. The next morning when I saw his chemistries, and I'm like, wow, his sodium level is low, like 130, 129. First thing I ask for is a chest x-ray, and then once we see the chest x-ray, I want a CAT scan of the chest. Well, now he's angry with me because he got admitted for one thing, and now the doctor has found something else. And so we have to spend time explaining these things to our patients, why a low sodium level can be due to free water retention due to SIADH, which can be due to any of these types of tumors, but especially lung tumors. Also in clinical practice, I was filling in for another doctor, and I saw a patient who was obviously a longtime smoker, and he looked very frail. And when I looked at his chemistry, his sodium levels were very low, and he was being prescribed salt pills as if he's losing sodium through his kidneys. And what we ended up doing is getting a chest x-ray, and he turned out to have advanced lung cancer. And so be on the lookout for this. Low sodium levels aren't because of low sodium loss in SIADH, they're because of free water retention, and that free water retention can be due to these tumors making analogs of antidiuretic hormone. And so when I was in practice, I saw a lot of lung tumors that were heralded by, identified by SIADH, which we'll see as low sodium levels. But again, those low sodium levels are dilutional. It's due to a retention of free water. All sorts of central nervous system drugs can cause antidiuretic hormone secretion as well, resulting in syndrome of too much antidiuretic hormone, syndrome of inappropriate antidiuretic hormone. Maybe that I should stand for increased. Again, drugs can cause SIADH, and there's some listed here. There are plenty of others. I had a partner come to me once and hand me the chart and say, why do you think that they're hyponatremic? And my first question is, well, what central nervous system medications are they on? Are they a smoker? Have they had a chest x-ray? All right, something else to keep in mind about the endocrine organs is what happens when they're traumatized, because we'll see this with thyroid disease. We can see this with any of the organs, the endocrine organs that store hormones. And so, oh great, we have this little bottle of hand sanitizer, and this is a great example. And so here is my endocrine cell, and it is all full of endocrine hormone, all right? And then if something happens, it's in a car accident, and it gets banged against something really hard and breaks loose, well, this hormone ends up everywhere, all right? And so the neurologic injury can result in too much hormone, all right? Excessive antidiuretic hormone secretion. And so being on a neurosurgical ICU, we'd see somebody after a car accident, after the first few days of their little cells of hormones getting broken and released, then we see hormone levels skyrocket. All right, well, after we've broken the bottle, it's empty and it quits working. All right, and so then what can we see down the road? So neurologic injury can cause excessive antidiuretic hormone to end up in the blood at first, but then once that organ's damaged over time, we'll see the opposite. And so be on the lookout for that. If you're ever in trauma, if you're ever doing neurosurgical stuff or you're involved in trauma, you'll see that these endocrine organs, when they get released, the first thing they'll do is secrete too much of their hormone, and then you'll notice about a week later there doesn't seem to be enough. So don't be surprised by that. Neurologic injury doesn't always result in SIADH in the long term. Severe neurologic injury can result in SIADH at first, and then you end up with the opposite of SIADH down the road, central DI, and we'll talk about that. All right, lithium can block the effects of antidiuretic hormone on the tubules. That's why lithium causes the opposite, diabetes insipidus. Demeclocycline, declomycin, can also be a drug that interferes with the effects of antidiuretic hormone on the renal tubules. However, it's usually water intake regulation, putting them on fluid restrictions. That's what we call it clinically. You see somebody with SIADH, we want to put them on free water restrictions until we can either deal with whatever the offending process is. So we want to put them on a fluid restriction to prevent us taking, the patient taking in dietary intake of free water when the body is already retaining free water. You might see these drugs used in SIADH, but again, volume restriction is how we want to treat SIADH the majority of the time. All right, well, this is where it gets confusing for people. Please do not confuse diabetes insipidus with diabetes mellitus. Mellitus comes from the Greek word, I think, for honey. Insipidus doesn't. And so diabetes mellitus got its name because it had sweetness to it. Insipidus did not. All right, so with diabetes insipidus, they have free water loss, and this is what I want you to know about diabetes insipidus. Again, diabetes mellitus is a disorder of glucose regulation, the diabetes we all know about, but there's another diabetes out there that's confusing for people. Diabetes insipidus is completely different. Diabetes insipidus is involved in losing free water. And there are basically two reasons for this. Either the brain's not making antidiuretic hormone, and so we can lump the top two, either a decreased production of antidiuretic hormone by the hypothalamus or a decreased secretion of antidiuretic hormone by the posterior pituitary gland. I don't need you to know the difference between these two things. They should be lumped together. And so this is central DI. That means the brain, the pituitary, is not releasing enough antidiuretic hormone. That's central diabetes insipidus. All right, well, maybe the receptor is not functioning, and that's called renal or renal DI, and so nephrogenic DI. And so remember, when we talked about diabetes mellitus, there were two types. One of them, we didn't make enough insulin. The other type, type 2, the receptor wasn't working. So we see the same thing with diabetes insipidus. One of them is caused by a failure of antidiuretic hormone to be produced. The other one is due to the receptor failing to sense the antidiuretic hormone. So again, diabetes insipidus is the opposite of syndrome of too much antidiuretic hormone. And so these people have very large amounts of urine. They're diuresing excessively. And so about 1.5 liters of urine each day is normal. And here somebody with DI is urinating 5 liters. That's a gallon. 20 liters, that's certainly more than a gallon. That's like 3-4 gallons right there. And so what are they urinating? They're urinating out their free water because either the body is not making antidiuretic hormone, the brain is not making antidiuretic hormone, or the kidneys are not sensing it. So again, the manifestations of diabetes insipidus, the clinical features of diabetes insipidus are polydipsia and polyuria. And we saw that with diabetes mellitus. That's why they share their names, because when these disease processes were being named, they didn't know the difference. And so the word diabetes actually means polydipsia and polyuria. Now with diabetes insipidus, we expect high sodium levels, not because they're taking in sodium, but they're losing free water. We're evaporating free water out of the saltwater aquarium. So they're hyperosmolar, they're hyperosmolar. They have excessive solutes in the blood, again, because of free water loss. All right, so this used to be the surprise, but now I've led up to it the entire time. Hopefully you guys will remember this. This is why diabetes insipidus and diabetes mellitus, even though they're completely unrelated, they share terms because of their symptoms. Because in diabetes mellitus, the disorder of glucose regulation, glucose is an osmotic diuretic increasing urine volume, which results in polyuria and polydipsia, excessive urine and excessive thirst. We see the same symptoms in diabetes insipidus, but for a different reason. In diabetes insipidus, their increased urine volume is not due to glucose in the urine. Their increased urine volume is due, their diuresis, let me start over. In diabetes mellitus, the disorder of glucose regulation, the increased urine volume is due to the fact that glucose is an osmotic diuretic, increasing urine volume, causing free water loss. In diabetes insipidus, we're either missing antidiuretic hormone or not sensing the antidiuretic hormone. And so that's why there's the increased loss of free water, the increased volume of urine. And so that's why, even though the diseases are completely unrelated, they still get the word diabetes, because again, diabetes comes from polyuria and polydipsia. And in the ancient times, to test the difference, we'd have to taste the urine, and that's exactly what they did. And so somebody who had polyuria and polydipsia, and their urine was sweet, that's where this word came from. And if it wasn't, that's where that came from. And so if you look at the history of these two words, where they came from, it gets even more fascinating. So yeah, we used to do that sort of thing. I never did that because I did actually grow up in the age of modern medicine. So please remember, DI is a disease of antidiuretic hormone. Diabetes mellitus is a disorder of glucose regulation. But because they're both characterized by polydipsia and polyuria, they share that diabetes name from way back in history. And again, there's two major types. Neurogenic means the brain is not making antidiuretic hormone, not making vasopressin. Nephrogenic means there's something wrong with the kidneys and it's not sensing antidiuretic hormone. And so be on the lookout for neurogenic diabetes insipidus, which is due to failure of the pituitary to make the antidiuretic hormone. All right, so we talked about SIADH being caused by neurologic injury. And again, when we have our cells full of hormone and they break, that hormone's released in the blood supply, and those hormone levels then are up. And so that's why after head trauma we can see SIADH. However, now that the pituitary has been damaged and released its hormone, maybe down the road we'll see diabetes insipidus in the long term from injury. And so again, I wanted you to be aware that you might see those opposites when you're talking about injuring the endocrine organs. At first you'll see high levels and then later you'll see low levels. We see that especially with thyroid disease. Things like Hashimoto's can do that with the thyroid. But back to our regularly scheduled program, two types of DI. Neurogenic, meaning the brain is not making antidiuretic hormone. Nephrogenic means the kidneys are not sensing the antidiuretic hormone. Again, with the treatment of SIADH or DI, the answer is usually, what you'll see most commonly done is regulation of free water. And so with SIADH, with them retaining too much free water, we'll put them on a fluid restriction. With DI, the opposite, while they're losing free water, what we'll want to do is replace it. And so something common that you'll see, especially with neurogenic DI in a neurosurgical unit, is that we replace the free water with a hypotonic solution that's essentially equal to the urinary losses. And so we'd use normal saline, and on an hourly basis, however much they urinated would be how much fluid we ran in their IV over that hour. And so that's what I used to see commonly. Now, if the brain is not making antidiuretic hormone, then replacing the antidiuretic hormone makes sense. Desmopressin, DDAVP, is an analog of antidiuretic hormone. Has all sorts of uses. We can use it orally, intravenously, or as a nasal spray. And even though we've listed this as a treatment for DI, let me see if it's on my slides. The most common reason that you're going to see DDAVP used is in the treatment of a blood clotting disorder. And so I want you to keep that in mind, that even though we use DDAVP in the treatment of neurogenic DI, the most common reason that we use DDAVP is the treatment of people with a certain kind of bleeding disorder. Something that's complicated with diabetes insipidus is here we're using a drug for diabetes mellitus to treat the diabetes insipidus, and now everyone's completely confused, and so I just wanted you to be aware of that. This has to do with the antidiuretic hormone circulating, works better and stimulates endogenous release of antidiuretic hormone. We're not going to see too much of that, but I wanted you to be aware of that. If you're doing psychiatric stuff, then you might see a lot of people with manic depression, bipolar disorder on lithium, and we will check their sodium levels regularly to make sure that they're not getting nephrogenic diabetes insipidus, because lithium blocks antidiuretic hormone on the tubules. And so if you're in the psychiatric business, you got somebody on lithium, you're going to get regular chemistries on them to make sure that they're not developing nephrogenic DI. All right, to make things even more confusing in the nephrogenic DI business, they use diuretics to treat DI. Now wait a minute, diuretics are supposed to increase urine volume, and DI is already a problem of excessive urine. What are they thinking? And I get emails about this, and I want you to research this if you're confused about these things. Thiazide diuretics increase urine volume in a normally functioning kidney. However, in a disease state like nephrogenic DI, their functioning actually slows the filtration rate, and this allows the kidneys to spend more time absorbing free water. And so I get a lot of people who make it this long in the course and follow very carefully are confused by this. But I want you to take a look at this and make sure that you're not confused by the word diabetes and the difference between insipidus and mellitus. And remember that DI, diabetes insipidus, is increased urine volume. And one of the things that you'll see is using diuretics but having the opposite effect. The diuretics really have the opposite effect on somebody with neurogenic DI. All right, well, there's a reason we don't cram that into the end of our diabetes lecture. Let me grab the slides that we're actually supposed to be doing today, and halfway through that we'll have to stop and take a break and spend 3 lectures talking about endocrinology. So on your schedule, it might have 2 lectures. In the old days, we were able to cram this into 2 lectures. Today, in the modern era, it takes 3 lectures to get through endocrinology. So we'll move back and get started in your notes with endocrinology 2. Let's talk about the adrenal glands. Your notes might be out of order. However, all of the information is still the same at this point moving forward. So if you can shoot me an email if your notes are out of order, and I'll make sure that they match up for fall. That being said, the adrenal glands add above renal the kidneys. And so the adrenal glands are located on the superior pole of the kidneys. However, they are retroperitoneal. They are behind the peritoneal abdominal lining, which is fun to talk about in anatomy. However, I don't think that's too much importance for clinical pharmacology. Again, all of the endocrine organs are like multiple organs in one. And so we talked about the adrenal medulla down at the bottom, talking about adrenaline when we talked about adrenergic, adrenal, adrenaline. We're talking about the adrenal medulla, all right, because that is what secretes catecholamines to regulate all sorts of things, including blood pressure. All right, well, the adrenal cortex, we don't use adreno words to describe the adrenal cortex. We're going to use cortico words to describe the adrenal cortex. And so we talked about the adrenal medulla when we talked about sympathetic nervous system pharmacology. And again, the adrenal medulla releasing adrenaline into the body to communicate with organs is part of endocrinology. But we talked about it during autonomic pharmacology. Now we're going to talk about the adrenal cortex, and it makes what's called the corticosteroids. Cortico meaning adrenal cortex, steroids just meaning sterol rings involving cholesterol. In social media, steroids refer to any kind of anabolic drug that athletes would use to increase performance. In pharmacology, steroids are any substance that is based on cholesterol. All right, so if we look at a cartoon of the adrenal gland, they like you to think that the adrenal gland is actually stuck to the kidney, with the inside being the medulla, the outside being the cortex. But if you actually peeled the peritoneum away, you'd realize the adrenal gland and the kidneys are next to each other, but they're actually separated by that layer. All right, so the outer layer means cortex, which means tree bark. The outer layer of the adrenal gland is referred to as the cortex. That comes from Latin tree bark, I believe. So when we talk about adrenocortico, we're talking about adrenal cortex, and we won't even see that adreno word used to refer to adrenal cortex stuff. We'll just see cortico words used to refer to adrenal cortex hormones. All right, like cortisol comes from the adrenal cortex. Cortisol is a glucocorticoid, and we'll talk a lot about glucocorticoids. when we talk about anti-inflammatory processes, when we talk about autoimmune processes, when we need an anti-inflammatory. Cortisol, it's the same thing as hydrocortisone. For the purposes of this course, cortisol and hydrocortisone are the same thing. Your body makes cortisol as a glucocorticoid, and it's available in a tube called hydrocortisone, and we can also use hydrocortisone IV. And so you'll hear drugs that are related to hydrocortisone referred to as glucocorticoids because among the many functions that they have, glucose regulation is one of them. All right, so when we talk about the adrenal cortex, when others talk about the adrenal cortex, we'll divide it into like 3 hormones: cortisol, aldosterone, and then the androgens. However, there is a spectrum of hormones that the adrenal cortex make that has in-between functions of cortisone and aldosterone. And so even though clinically we'll think of cortisone being one hormone and aldosterone being the other hormone, there's a collection of hormones that have function that's in between the function of cortisol and aldosterone. And then on top of all of that, we have the androgens, the male hormones as well. If you recall, we talked about a diuretic, spironolactone, aldactone, and because it interferes with aldosterone receptors, it also interferes with adult hormones. That's why we see drugs that affect aldosterone, like spironolactone, our potassium-sparing diuretic, will cause breast growth in men because of this slide right here. The adrenal cortex not only makes cortisone and aldosterone and all sorts of hormones in between, it's also involved in making adult hormones. If you look at a real pharmacology book, oh, that's good. It's been a while since I've seen these slides right here. They've been hidden from me. And so I'll make sure these are in your notes, or you can just look up the androgen and estrogen pathway, the glucocorticoid pathway, and the mineralocorticoid pathway. And notice they all start with cholesterol. And cholesterol here, pregnenolone, can either end up being cortisone, which can be aldosterone, or it can go this way and become cortisol, or it can come this way and become the androgens, corticosterone, aldosterone. So here, the 3 points I want you to see: aldosterone, cortisol, and the androgens. Testosterone is converted to estradiol. All right, I don't think I wanted to go through all that. That's what I wanted you to see right there. Cholesterol, one of the intermediate steps to go to aldosterone is to go through progesterone. Progesterone can be an intermediate step in the formation of testosterone, as well as estrogen, estradiol. And so that's what I wanted you to see from this, is those are all related to each other. And we can use one to make the other. And so that's why it's complicated for people, because there's all sorts of these intermediate steps that have function somewhere in between aldosterone, cortisol, and then progesterone, testosterone, and estrogen. All right. Again, the steroid hormones are all based on cholesterol. I'm pretty sure that this is in your notes. And here, cholesterol goes to progesterone, which can then be converted either into aldosterone, cortisol, testosterone, and then estrogen, estradiol. So the androgen steroids are based on cholesterol, progesterone, testosterone, estradiol. When you look at the top 200 list, you're going to see all sorts of estrogen analogs used in birth control pills. And so that's one of the things you'll notice if you go through the top 200 list, and we see all of the ingredients that are used for birth control pills. There'll be analogs of either mostly estradiol and progesterone. Then we've taken a large chunk off that list, and so I want you to spend some time looking at the top 200 list and realizing how many analogs of progesterone and estradiol are on that list. All right, cholesterol can eventually be made cortisol, which is our glucocorticoid. So when we talk about prednisolone and prednisone and methylprednisolone, those are glucocorticoids. We'll talk more about the glucocorticoids as we go along. Cortisol is similar to hydrocortisone. And cortisol, again, is made by the body, a natural occurring hormone, as is aldosterone, which is our mineral corticoid. And so these are all forms of steroids. When we talk about steroids in pharmacology, we're talking about all of these hormones right here and their intermediate steps. Steroid hormones have receptors on the surface as well, especially when we talk about central nervous system stuff. I left those cartoons out, but steroid hormones are also fat soluble. They can pass through the cell membrane and activate all sorts of plants for protein synthesis by activating messenger RNAs. And so that's what this cartoon is supposed to show you. Much of the activity that we see with steroid hormones is their ability to get inside the cell and activate messenger RNAs, so those messenger RNAs can go to ribosomes and form proteins. But I assure you there's plenty of surface receptors for the steroid hormones as well. All right, so let's talk about cortisol, hydrocortisone. It's released by the adrenal cortex in response to low blood glucose concentration. That's how cortisol, hydrocortisone, and the related glucocorticoids got their name, because they were released in response to low blood glucose levels, because your body considers low blood glucose levels to be very stressful. And so cortisol will be released in times of stress, trauma, burns, surgery. Keep this in mind. And so some people will, if they have a certain disease process, Addison's disease, they'll need a hydrocortisone injector in case they have stress or trauma. All right, so cortisol increases blood sugar through the process of gluconeogenesis. It also facilitates the breakdown, the metabolism of fat, proteins, and carbohydrates. It also has inflammatory effects by preventing the formation of prostaglandins and interleukins as well. And so this is the most common use of the glucocorticoids to decrease inflammation. Hydrocortisone can also affect emotional centers in the brain, and I think we'll get to that very soon. This is what we really want you to know right here. Mammals with no cortisol don't live very long. Cortisol is essential to the survival of a human. And so patients with no cortisol, they must have replacement treatment. And we're going to see this later. We're going to see patients who have some kind of synthetic cortisol that they're taking by mouth. Maybe they're on prednisone, and they get regular doses of prednisone. And that fools the brain into thinking that the body doesn't need to make cortisol because the body's already getting a source of glucocorticoids. So the patient's taking prednisone, and the body's not making any cortisol. However, the prednisone functions as a glucocorticoid just fine. Well, then they come to the hospital, and maybe they're NPO for surgery, and they come off the prednisone. Well, the body's not making any cortisol, and we have to give them replacement treatment, or they won't survive. And so this used to be a big problem in hospitals somewhere around the 80s and 90s, and we started realizing how essential it is to make sure that we have an algorithm to replace the glucocorticoids. So if you have a patient who's taking glucocorticoids on a regular basis, when they get to the hospital and they're made NPO, when they're not given anything by mouth, when they're not given their medications by mouth, they must have replacement therapy through the IV. All right, so cortisol is released from the adrenal cortex entirely in response to adrenocorticotropic hormone, which comes from the anterior pituitary. So when we're talking about the anterior pituitary keeping us in front of the growth curve and secreting tropic hormones, here is one of them, adrenocorticotropic hormone, ACTH. All right, so ACTH signals the adrenal cortex to release cortisol. So glucocorticoids are produced in the zona fasciculata of the adrenal cortex, and glucocorticoid receptors are found in the cytoplasm and the surfaces of all sorts of cells. And I think we talked about that. Glucocorticoids and cortisol in particular are essential for numerous homeostatic functions, especially in times of stress, and so we need to keep this in mind when we have surgical patients. They need cortisol, more cortisol, not less. Infection, dehydration, trauma, these are stressful times when the body requires more cortisol. And so if something's going on and they're not getting enough cortisol during surgery, infection, dehydration, trauma, then we're going to have a bad outcome. So making sure that they're not in a situation where they are in a hypoadrenal state is essential for taking care of people during surgery, infection, dehydration, trauma, etc. So adrenocorticotropic hormone and cortisol levels are dramatically increased to meet the physiologic demands placed on the body due to surgery, infection, dehydration, trauma, etc. On the slides, we've divided the glucocorticoids into short-acting, intermediate-acting, and long-acting. What I want you to know that these are all glucocorticoids. Hydrocortisone, prednisone. Prednisone is the prodrug for prednisolone. Methylprednisolone, also known as a Medrol. Triamcinolone, paramethazone, fluprednisone, betamethasone, dexamethasone. The differences in these glucocorticoids is something that I want you to take a look at in your clinical discussion section. I'm not going to get much into that today. But I do want you to know for all sorts of indications for glucocorticoids. Adrenal insufficiency, which is Addison's disease, they're not making cortisol. That makes sense. But suppressing various allergic, inflammatory, and autoimmune disorders, that's what we see the glucocorticoids used for. All sorts of allergic reactions, all sorts of inflammatory processes, all sorts of autoimmune disorders will be treated with glucocorticoids, among other things. Glucocorticoids are essential in the treatment of asthma. When we talked about asthma, we talked about survival depending on the use of inhaled glucocorticoids. We'll use it as an immunosuppressant, especially in, we'll use glucocorticoids as immunosuppressants in somebody who's had a transplant. We'll also use glucocorticoids in cancer chemotherapy because they make white blood counts go up, and hopefully I have the right slides for that. There we go. All right, so when somebody's in the hospital and they're on glucocorticoids, or even if they're at home on glucocorticoids, we'll see increased blood sugar levels. And so somebody comes to the hospital, they have some kind of inflammatory process, we'll put them on a glucocorticoid like prednisone, and then we see their blood sugars running in the 200s, and they're not diabetic, and then we'll try to put them on sliding scales and try to treat them like a diabetic, when really this acute increase in blood sugar is not going to have a chronic effect for a lot of years. And so be on the lookout for increased blood sugar levels due to glucocorticoids. All right, increased white blood cells result in something called demargination. Make sure we get this right. I know there's people out there watching this now, so we're going to be and sometimes it takes me a long time to find this stuff. All right, so demargination is you have all sorts of white blood cells that are out of circulation, and they stay on the margins of the blood cells waiting for foreign substances so they can go do their thing that we'll talk about in immunology coming up. Fighting with foreign substances, and so they hang out in these margins outside of the blood vessels, between the blood vessels, whatever's outside of the blood vessel, we call that the margin, and that's where a lot of white cells hang out, in these margins. Well, glucocorticoids will cause these white blood cells to leave the margins and go into circulation. And so that's what demargination is, coming out of those marginal spaces and getting into the blood supply. And we'll also see this in the bone marrow, where the white blood cells will be released at an earlier stage. And so we'll use glucocorticoids. When we're using glucocorticoids, we might see an increased white blood cell count. And so you'll have to be careful. You'll have somebody come in the hospital, maybe they're having an exacerbation of bronchitis, and we put them on a bunch of glucocorticoids, and the next thing we see is an increased white blood cell count, and we worry, well, is that due to infection or is that due to something called demargination? We'll use prednisone in the treatment of leukemia, specifically to increase white blood cells because of this concept called demargination, taking them out of the margins and getting them into the vascular space. So be on the lookout for that. Later, we'll talk about osteoporosis. This is due to a loss of bone mass. And we have to be very careful in women who are at risk for osteoporosis. We have to be very careful using glucocorticoids in them because it interferes with their bone metabolism, making osteoporosis worse. Well, when they taught us this in school, I didn't really believe it too much until I saw this happen a couple of times and made me a big believer. And so glucocorticoids, there are certain people out there, and sometimes they know who they are, sometimes they don't. But putting them on glucocorticoids can cause subtle emotional changes, very large emotional changes. Putting somebody on glucocorticoids can make them completely psychotic. I've seen that happen before. We have people in the hospital who become acutely psychotic. Well, one of the first things we worry about is delirium tremens. There's alcohol withdrawal. There's a time window for that. In older people, we worry about urinary tract infection causing mental status changes. Something I want you to be on the lookout for is a big dose of corticoids causing a mental status change in your patients. It's very rare, but it's easy to miss. And I didn't think too much of this until I saw it profoundly. And one time we saw it, it was like, well, yeah, this happens to me when you give us glucocorticoids. Okay, well, we'll try to remember to put that in your chart. And so be on the lookout for this. In your clinical discussion section, again, there's all sorts of glucocorticoids and their indications. We're moving on and talking about aldosterone. Something I wanted you to know early on is that hydrocortisone also has all the properties that aldosterone has. So hydrocortisone not only has glucocorticoid properties, cortisol also has aldosterone properties as well. So cortisol is like both cortisol and aldosterone in one. Aldosterone does not have cortisol properties. Aldosterone quite simply has mineral corticoid properties. It has nothing to do with ACTH. It's released in response to low sodium levels. So again, cortisol is released in response to adrenocorticotropic hormone. Aldosterone is released in response to low sodium levels in the blood. So aldosterone helps keep sodium in the blood and potassium out of the blood. That's why aldosterone antagonists are considered potassium sparing. But again, they interfere with the proper breast growth in men, causing breast growth when we use aldosterone antagonists, because again, the adrenal cortex is involved in the formation of the androgens, the adult hormones. So again, aldosterone keeps sodium in the blood, pushes potassium out into the urine. The mineral corticoids are produced in the zona glomerulosa of the adrenal cortex. I think I cut and paste that from somewhere. I don't think I need you to know that, although they will use these words when they talk about this in clinical pharmacology. They'll talk about zona glomerulosa cells producing the mineral corticoids. All right, so there's all sorts of mineral corticoids. Aldosterone is the one we refer to. It's stimulated primarily by the renin-angiotensin-aldosterone system. Remember, when the kidneys are low on volume, they release renin, which converts angiotensinogen to angiotensin 1. Angiotensin 1 is converted to angiotensin 2, which is also a vasopressor, but also stimulates aldosterone. All right, so those things are related. And again, they're all part of the endocrine system working together to respond to low volume status, hyponatremia, or hyperkalemia. So aldosterone enhances renal retention, and that increases not only sodium concentration, but pulls water with it. This stimulates antidiuretic hormone and water retention. The net result is an increase in total body volume and increased renal potassium excretion. All right, this is what I want you to really know from this lecture. Is Addison's is hypoadrenalism. Cushing's is hyperadrenalism. So you think about the adrenal hormones, they're missing in Addison's disease. If you think about Cushing's, there's too much. Right? So again, these are opposites. All right, so we'll start with Addison's disease, hypoadrenalism. It can result from failure of adrenal cortex to produce adrenal cortices to produce adrenal steroid hormones. It can either be a mineralocorticoid deficiency, a glucocorticoid deficiency, or both. For this class, we'll talk about both. Sometimes you can have one without the other, but that's, we won't go into that. For Addison's disease, I want you to remember, it's just those people are missing glucocorticoids and mineralocorticoids. All right, something that you need to know in the dental hygiene business is that something we see commonly with Addison's disease are brown spots, especially inside of the mouth. That's why we teach this to people in the dental hygiene business, but they can have brown spots anywhere. Sometimes the doctor will look at my skin and see the brown spots and say, oh, well, you're having adrenal stress. And that may or may not be true, but this is true right here. All right, so melanocytes, and I wish I'd covered this, note to self, earlier. Melanocytes are the parts of the cells in our skin that make pigmentation, little brown spots. Some of us has much larger brown spots than others, but these little brown spots, they're made by melanocytes. And melanocytes have melanocyte-stimulating hormone that comes from the anterior pituitary. All right, so in hypoadrenalism, in Addison's disease, there is a lack of adrenal cortex hormone. And so what happens? Well, there's an increase of adrenal corticotropic hormone. The brain senses that there's no adrenal cortex hormone, and it starts yelling at the adrenal cortex as loud as it can with really high ACTH levels. These high ACTH levels come from the brain, and they're screaming at the adrenal gland to get to work because the adrenal gland is not working. And so when the gland is not secreting its hormone, the tropic hormone coming from the brain that stimulates it will be sky high. And so here we have real high ACTH levels because we are not making adrenal cortex hormones. Well, the melanocytes, they think the brain's screaming at them. And oh, well, we've got to work harder. And so even though the adrenal cortex won't respond to the high ACTH levels, the melanocytes will, because ACTH, adrenocorticotropic hormone, is very similar to melanocyte-stimulating hormone, and the melanocytes are easily confused. So the melanocytes will work harder when we are having episodes of hypoadrenalism or chronic hypoadrenalism, which results in high levels of ACTH. And so this is what we want you to know in the dental hygiene business, that people with Addison's disease, sometimes the first time we find that is by increased brown spots in their mouth. And so it's very important for dental hygienists to realize this and see that if there's this increase in brown spotting in the mouth, that can indicate Addison's disease. All right, so with Addison's, we would expect deficiency of mineralocorticoids, which would result in sodium loss and potassium retention and a loss of fluid volume as well. And then with the glucocorticoid deficiency, they would have difficulty regulating glucose, and they would have hypoglycemia. Over time, there's failed gluconeogenesis. Weakness, fatigue, weight loss, anorexia, nonspecific symptoms, skin hyperpigmentation. This is something that we want to be on the lookout for Addison's disease. So with the volume loss, we can have hypotension, hyponatremia because of the failure to retain sodium, hyperkalemia because of increased retained potassium, nausea and vomiting. These can be symptoms of Addison's disease. All right, well, what's interesting about Addison's disease is hydrocortisone, cortisol replacement therapy, works great because it has both mineral and glucocorticoid properties. Cortisol not only has glucocorticoid properties, and we describe it as a glucocorticoid, but it has mineralocorticoid properties as well. It has full mineralocorticoid properties. So something I want you to be able to do as you look carefully at the glucocorticoids is identify what kind of mineralocorticoid properties does that glucocorticoid have? And hydrocortisone, cortisol, has both mineral and glucocorticoid properties. Some of the synthetic glucocorticoids that we use don't have any mineralocorticoid properties whatsoever. And that's something that we won't get into today, but I think there's something about that in your clinical discussion section. Something I want you to know about Addison's disease is they might carry a hydrocortisone auto-injector. They might have an injector where they can give themselves an additional dose of hydrocortisone when they are undergoing stress, exercise, something unexpected, flu, nausea and vomiting, physical exertion. So be on the lookout for that, because a lot of people, they'll carry auto-injectors, EpiPens for bee stings, allergic reactions, and you think, oh, well, is that what they carry a hydrocortisone pen for? No, the hydrocortisone auto-injectors are usually for Addison's disease. And so if you keep your eye out, you might come across somebody who has Addison's disease. Maybe they'll have a little medic alert bracelet, and maybe it tells them that if they're having a problem, they need an injection of hydrocortisone. Again, there's other glucocorticoids we can use, depending on whether they're having mostly glucocorticoid problems or mineralocorticoid problems. What I want you to know is hydrocortisone replacement therapy is used in Addison's disease because, again, hydrocortisone, cortisol, has both mineralocorticoid and glucocorticoid properties. Cushing's is hyperadrenalism, too much adrenal hormone for whatever reason. And so I just call it Cushing's, hyperadrenalism, the opposite of Addison's, excessive glucocorticoid either production or exposure. I used to get a lot of emails because I didn't spend enough time differentiating Cushing's disease with Cushing's syndrome. I think from a clinical perspective, I think Cushing's and Cushingoid is just fine. However, for the sake of detail, Cushing's disease is caused by a pituitary adenoma, a functional adenoma that secretes too much adrenocorticotropic hormone. But syndrome is caused by any other reason for excessive glucocorticoid exposure. So again, Cushing's disease is specific to the pituitary adenoma secreting too much adrenocorticotropic hormone. Cushing's syndrome and all the other Cushing stuff is just quite simply an excessive glucocorticoid for whatever reason. I don't think we're getting closer to using the difference between these two. Usually we just see words Cushing's to describe any of this. So again, if they're exposed to excessive glucocorticoid levels, whether excessive production or exposure, then there's going to be a change in their fat metabolism. There's going to be increased gluconeogenesis. They're going to retain fluid. They're going to retain sodium. Maybe we'll see something called moon phases and hyperpigmentation in Cushing's, and so this child is suffering from Cushing's, and we're trying to identify this moon-shaped phases, and then we can see the hyperpigmentation. There's all sorts of problems that refer to as a buffalo hump, and what I want you to see here is just an impaired fat metabolism, especially right here in our upper posterior thorax, and we can see a little bit of moon phases and a little bit of hyperpigmentation. Again, you're not going to look at a single picture and determine these things, but if you meet your patients and you know them, you watch these changes over time, you can be aware of it. There's all sorts of reasons to have stria, these marks. Here we have them in the armpits and posterior, but Cushing's can result in stria. Because of the excessive amount of glucocorticoid, either production or exposure, this can result in insulin resistance and can result in diabetes mellitus type 1 because the pancreas is busy releasing so much insulin that eventually it burns out. And so severely overstimulated insulin production cells in the pancreas will result in failure. And so somebody who has Cushing's for whatever reason over time can result in diabetes mellitus type 1. Again, this can be due to prolonged administration of high doses of corticosteroids. There's all sorts of people out there that because of the need for glucocorticoids. They start showing cushingoid appearances due to the prolonged administration of the high doses of corticosteroids. An adenoma, a functional adenoma of the adrenal cortex will secrete too much cortisol. That'll be Cushing's syndrome. Or a functional adenoma of the, and it doesn't have to be a malignancy, it can be a functional adenoma of the pituitary that secretes too much adrenocorticotropic hormone, and that's technically Cushing's disease. So there's all sorts of reasons that we see this Cushing's type appearance in our patients, either large doses of corticosteroids, or they can have an adenoma of the adrenal cortex that makes too much cortisol, or they can have an adenoma in the anterior pituitary secreting too much or adrenocorticotropic hormone. All right, well, if Cushing's is caused by excessive corticosteroid use, we have to gradually taper them. Anytime we're taking away a regimen of corticosteroids, we have to gradually taper them off. And so if you've seen a Medrol dose pack, if you've seen a prednisone dose pack, they start with, oh, you take 6 pills the first day, and then you take 5 pills the day after that, and then you take 4 pills the day after that, and you space the pills out over the day. So the first day you take 6 pills, and it'll be like 1 in the morning, and 1 right after breakfast, and 1 before lunch, and 1 at lunch, and 1 in the afternoon, and 1 before dinner, and 1 at dinner. And you take 6 pills over the course of the day. The first day, and then the next day you take 5 pills, and then the next day after that you space the 4 pills over the day. And the next day after that you space the 3 pills, and then 2, and then 1. And so the major burst is that first couple days of corticosteroids. And then after that, they have to be gradually tapered, quite simply because when we use exogenous sources of corticosteroids, when we use exogenous sources of glucocorticoids, that tells the brain to stop releasing ACTH. That's called ACTH suppression. So ACTH will go down to 0. That means your adrenal cortex will quit making cortisol, because your body feels like the exogenous corticosteroids are functioning as replacement, and they do. And so people that are on exogenous glucocorticoids are not making cortisol internally, because the body is relying on this external corticosteroid use, this external glucocorticoid use. So this is important to remember when patients come into the hospital who are on large doses of glucocorticoids. They're suppressing ACTH production. So they're not making endogenous cortisol because of ACTH suppression. I think I've made this point. Well, then what happens? The surgeon makes them NPO because we're getting ready to have surgery, and so we want them to stop eating by mouth so that they won't aspirate during the surgery. And now they don't have any endogenous source of glucocorticoids. And so even though when they are on large doses of glucocorticoids, they might have this cushingoid appearance. They might look like they have Cushing's syndrome. But if we remove the corticosteroids, if we remove the glucocorticoids, we can end up with a severe Addisonian crisis. We used to see this a lot in surgical settings, early 90s, late 80s. And so we have to give them IV replacement. Now pharmacists have, and the hospitals have, charts where if patient is taking a certain amount of prednisone or prednisolone, methylprednisolone, on an outpatient basis, and that has to be stopped, then we have a menu of IV replacement that we can use. And this is essential for patients who are coming into the hospital taking large doses of glucocorticoids, or people who have adrenal suppression. For whatever reason, we need to be replacing the endogenous cortisol with some kind of exogenous source of glucocorticoids. And so this is a life and death thing, which is pretty tough to talk about so late in the lecture, but for those of you who've made it this far, this is a very important concept for you to take forward when you're doing med-surg, when you're taking care of surgical patients, because all sorts of people have all sorts of stories about that. I think we are going to save this for next time, and so we'll start talking about the thyroid when we get to the third lecture for endocrinology. So until then, aloha.